This is episode 88 of the Psychcast by MD Edge, where we bring you interviews with leaders in the field of psychiatry and psychology, masterclass lectures, and relevant inspiration straight to your ears with new episodes dropping on Wednesdays. I'm the voice of MD Edge podcasts, Nick Andrews. Coming up later, the MD Edge Psychiatry Editor-in-Chief, Dr. Lorenzo Norris, welcomes Andrew Penn of the University of California, San Francisco. The topic today, psychedelic-assisted therapy. Before we get to This Week in Psychiatry, I wanted to mention something that we're doing at MD Edge Podcasts in an effort to improve the Psychcast and all of our shows. We have a simple listener survey available for any of you who want to leave some feedback. The goal of the survey is to learn a little bit more about you and improve the interviews, lectures, timing, production, and really anything that we can improve just for you, the listener. I know there's a ton of things to do in the day, but if you like the show or if you have any thoughts on improvement, please take a moment and answer a few questions. The survey is, of course, anonymous. You can find a link to it in the show notes. Okay, it's time for This Week in Psychiatry. This week in psychiatry, cognitive behavioral therapy, or CBT, and antidepressants have similar costs for major depressive disorder. This is according to new research published in the Annals of Internal Medicine. Dr. Eric L. Ross is a clinical fellow in psychiatry at Mass General in Boston. In the study, Dr. Ross and his colleagues created a decision analytic model for adults with major depressive disorder in the U.S. by using age and gender data from the sequenced treatment alternatives to relieve depression, also known as STAR-D. They simulated a cohort consisting of more than 62% women with a mean age of just over 40 years. Patients underwent cognitive behavioral therapy, or they received a second-generation antidepressant as first-line therapy. The researchers calculated the average quality-adjusted life years of both treatments at 1 year and at 5 years. The incremental cost-effectiveness ratio was set at $100,000 or less per QALY for cost-effectiveness. The results were adjusted for US dollars in 2014. The researchers also calculated the net monetary benefit of each treatment based on health and economic outcomes. At 1 year, Dr. Ross and his colleagues found quality-adjusted survival in patients who received CBT increased by 3 days compared with those who received second-generation antidepressants. However, there was a higher mean cost to the healthcare sector and to society. The average increased cost was $900 to the health system and $1,500 to society. They also found that CBT was not cost-effective at 1 year, with incremental cost-effectiveness ratios in the healthcare sector of $119,000 and $186,000 to society. Dr. Neil Skolnick is a professor of family and community medicine and the director of the family medicine residency program at Jefferson Medical College in Philadelphia. Dr. Skolnick says that cognitive therapy should be offered alongside antidepressants for treatment of major depressive disorder. He told MD Edge that CBT works as well or better than antidepressant medication, and since people learn skills that they can continue to use, it often has a long-lasting effect. He said that in his experience, cognitive behavioral therapy can be life-changing for those patients who are seeing a therapist that use CBT as the technique, and those patients put in the necessary work and commitment to make cognitive behavioral therapy work. Dr. Skolnick emphasized that not every therapist offers cognitive behavioral therapy, so healthcare providers should be aware of the type of therapy that they are referring their patients for and monitor that therapy whenever possible. He told MD Edge that clinicians should talk to their patients, present them with options, and then decide together with the patient how to approach major depression. He added that medications work, and for many, this is a good choice. Cognitive behavioral therapy works, and for many, that is a good choice. And for some patients, using both CBT and medications is the optimal choice. They were about equally as cost-effective. And that concludes This Week in Psychiatry. You can find news like that each and every day at mdedge.com/psychiatry, and you can find a link to this story in the show notes. When we come back, it's time for our masterclass lecture with Andrew Penn. Welcome back to the Daily Medical News. I am Nick Andrews. It's time now for our masterclass lecture on psychedelic-assisted therapy. Please welcome to the Psychcast, Andrew Penn.
I'm Andrew Penn. I'm a psychiatric nurse practitioner. I'm also an associate clinical professor at the University of California, San Francisco in the School of Nursing, where I teach psychopharmacology, among other subjects. I'm going to talk to you today about the reemergence of research into psychedelic-assisted psychotherapies. When I talk about psychedelics, the main agents that are in question and that are under study are MDMA, which is 3,4-methyldioxymethamphetamine, previously known as ecstasy, as a treatment, as an adjunctive treatment along with psychotherapy for treatment-resistant PTSD. The other large area of research right now is using the compound psilocybin, which is a naturally occurring compound in psilocybin mushrooms, as a treatment adjunct to psychotherapy for major depression. And there's been a lot of popular press about this. Michael Pollan wrote a book a year or so ago. Anderson Cooper just did a 60 Minutes piece on it. And there's been a lot of interest in the popular press. And so there's, as a result, there's been a lot of interest in the psychiatry community as well. And so I've been talking about how these medications work and the sort of mechanism through which that therapy is delivered. And it's really, one of the things that's really important to understand from the get-go is this is very different than how we do psychopharmacology now. So the way we do psychopharmacology now, we give people medication, we have them take it at home, and we have them come back and tell us how they're doing. And in this model, these medications are not going to be taken every day. In fact, they would never be taken home by the patient. They would only be given in a clinical setting, which is safe and contained, usually with two therapists who are going to be present the entire time of the treatment session. And those therapists would have worked with the patient in the days and weeks leading up to the psychedelic session, and would continue to work with them after that session is over. So that sort of bookending of psychotherapy, in addition to the careful tending to the psychedelic session with the same therapist, is what permits this to be not only physically safe, but psychologically safer as well. And so let's go ahead and take each of these compounds in turn. So MDMA is a drug that's been around for about 100 years or so. It really was sort of unknown and obscure. It was actually patented by the Merck company in 1912 it was a medicinal chemist patented it as looking at various different early development drugs. Nobody had any clue that it was psychoactive. It was resynthesized by a chemist by the name of Alexander Shulgin in the early 1970s, and when this drug was initially synthesized, it was being used. Remember, at this point in time, it was not a Schedule I drug. It was not even known by the DEA. It had not kind of gotten out into a recreational setting. It was being used by psychotherapists as a means of helping people resolve trauma. It was also being used in marital therapy as a means of helping people feel less defended and more connected. But then, unfortunately, it got out into the larger world. The genie got out of the bottle. And when that happened, there was a lot of panic because it was a fairly unknown drug. And the DEA put it on emergency Schedule I believe, in 1985. And that being on Schedule I made it so that it couldn't be studied in clinical trials because Schedule I is axiomatic. It says that this is a drug that has no medical use and has a high potential for abuse. And so when you go to the DEA and you say, I'd like to study a Schedule I drug, they say, well, by definition, it has no therapeutic benefit. So how do you study it? You can't study it. But if you can't study it, you don't know if it has therapeutic benefit. So through a lot of hard work, particularly in the case of MDMA, through an organization called the Multidisciplinary Association for Psychedelic Studies, or MAPS, through their tireless bootstrapped work, they have managed to bring this up to Schedule 3, it's still a Schedule 1 drug, bring it up to Phase 3 clinical trials, which are currently underway. And in this, the thought of why this may be helpful for psychotherapy is severalfold. Sort of from a phenomenological standpoint, so let me back up. From a biological standpoint, the drug is a potent releaser of serotonin, oxytocin, and prolactin. And that trio of chemicals allows the person to feel less of an experience of fear, which then allows them to engage more deeply in psychotherapy, to trust the psychotherapist more, and also to be able to withstand talking about traumatic material, which is often highly defended. The patient, somebody with PTSD, often will shut down when talking about a traumatic experience, or they'll feel flooded. And either way, they're not able to do psychotherapy in that state. And so the idea behind PTSD treatment being augmented with MDMA is that they're able to stay in that sort of optimal arousal zone long enough to make some progress in therapy. And then after the therapy is over, or after the drug session is over, the therapy doesn't stop there. And it's really important to understand that there's a period of integration therapy that happens where the subject in the study would meet with the same two therapists that they've been working with, and would continue to talk about the themes that came up in the MDMA session. And not only talk about them, but understand how to integrate those experiences into their life, and how they might make changes which they've been unable to make up until that point. So that's really where MDMA stands right now. It's currently in sort of early middle Phase 3 studies. There's 15 sites around the world which are part of that study, and the projections are that the data may be ready to present to the FDA sometime maybe as early as 2021, but it may take longer than that, as the trials, of course, take some time. So that's where things are with MDMA, and it's worth noting too that this is if this is approved by the FDA, that there will be a risk evaluation and mitigation system, a REMS, similar to what we would have with Clozaril or with Suboxone, or any drug that potentially has a risk profile that we want to be especially careful around. And so this will not be available to just anybody. It will be only available to people who have gone through certain training and have the ability to keep this drug in a safe place. This is never going to be a take-home treatment. This is always going to be something that is done in a therapeutic setting. So it's important to understand, sometimes when the news media reports on this, it sounds as if you're going to be able to walk down to Walgreens and fill a prescription for MDMA, and that's not the case. Excuse me. So let's shift gears to psilocybin. So psilocybin is a naturally occurring compound in psilocybe mushrooms. It works in part on the serotonin 2A receptor. And psilocybin-assisted therapy, I should say, has some similarities to MDMA-assisted therapy in that the drug experience is attended to by two therapists who are there the whole time, and those same two therapists would work with the patient in the preparatory and the integration period afterwards. It's thought that psilocybin may be effective for treatment-resistant depression, or depression in general, through a process in which, metaphorically, you can think of the brain of somebody who has depression as struggling to make changes. So it's in a state of sort of high rigidity and low flexibility. And so the brain, if you think of the brain as kind of a predictive machine, somebody who has depression, their prediction might be things are never going to get better, this is always going to feel terrible, people don't like me and I'm never going to feel well again. And that's their prediction. Now, maybe an erroneous prediction, but it can be a very fixed prediction, and it tends to inform the worldview of that person who has depression. So that rigidity often makes it difficult for the person experiencing depression to shift their attitudes, their behaviors, their emotional state. And so psilocybin has this interesting effect of causing a transient rewiring of the brain. I've heard it described as it's sort of like if you take a snow globe, a children's snow globe, and you shake it up, the snow settles down in different places that you're in. Sorry, talk too much. One metaphor I've heard described, sorry, this is going to take me a second. A useful metaphor for the way psilocybin works in the brain with regards to these sort of rigid, overly predictable network activity is, excuse me, I'm going to get a mint. Do you like one?
Yeah, thank you.
Okay. I know these things make noise on the microphone, so I'll tune up. So a useful metaphor with psilocybin with regards to this sort of rigidity in the brain in people with depression would be that of a children's snow globe. So when you take that snow globe and you shake it up, the bits of snow settle back onto the landscape, but they settle in a different way than they were before. And it's thought that perhaps this transient state of disorganization that happens under psilocybin allows the brain to reset in a way that is less rigid, perhaps more supple, more flexible, more able to perceive the world, maybe not so much as we fear it might be, but as it actually is. And that may be the thing that accounts for the antidepressant effect of psilocybin. Again, it's really important to emphasize that this is not a drug that's going to be taken by people on their own. This is never something you're going to be able to fill at your local drugstore. This is going to have a REMS program associated with it, and it's always going to be given in a clinical setting. So, just in the same way that anesthetic drugs are prescribed, they're prescription drugs, but you can't get a prescription for midazolam filled at your local CVS. That can only be given to you in a hospital setting when you're having a procedure done. So it'll be akin to that, and that's one of the things that's going to keep it from being diverted and misused. And so it's important to make that distinction when we're talking about these drugs, because unfortunately, psychedelics have somewhat of a checkered history from the 1960s, which is increasingly kind of fading behind us in history. But one of the downsides to that period was this sort of indiscriminate use of the drugs among young people and others, many of whom had experiences which they would probably now tell you are positive. I have to tell you, every time I talk about psychedelics at a conference, usually 2 or 3 people will come up to me quietly. These are often folks that have been around for a while, and they'll confide in me that they had these experiences in college and they've always stayed with them and they were very important to them. And these are our peers and colleagues. So these things have always been out in the culture, and that can be problematic. But it's really important to understand that that's not what we're talking about here. That we need to, just as we can talk about the treatment of ADHD and talk about the use of different amphetamine preparations without commingling it with methamphetamine abuse. Pharmacologically, those two compounds are quite similar. In fact, they're almost identical. But the context in which the drug is used is very different, and the disease state versus recreational use or substance abuse, misuse of substance is very different. And so I think it's not only possible, I think it's necessary for psychiatry to evolve its thinking around this in order to be able to avail our patients of any treatments that will work. Because frankly, a lot of our treatments don't work very well, and we see a lot of unresolved suffering. I work part of my time at the VA, and we hear about 20 veteran suicides a day. So there's a lot of reasons for that, but one of that is that we don't have great treatments for PTSD, or the treatments that we do have that are really good, such as prolonged exposure, are not tolerable for some people. And this may be a way of making treatment for PTSD not only effective, but also tolerable for people that can't do other evidence-based treatments.
And that concludes the lecture portion of this week's episode. It's time now for Dr. RK. Please welcome Dr. Renee Kohanski.
I appreciate the introduction as always, Nick. I was recently traveling. I wonder if that's where I got this cold. And there is no better place to people watch than the airport. Maybe that's where Stephen King got his idea for Under the Dome. Anyway, I am not a frequent flyer, so while I see certain general changes or shifts in what we've grown to accept as normal behaviors, they are magnified 1,000 times in tense situations such as flying. And when you don't fly often, you notice these changes. Now, personally, I love flying once I get through the security piece. I no longer have small children with whom I have to navigate. I love reading. So guess what? A delay means an extra book to read. And I've already mentioned the people watching. It's like a playground for a psychiatrist. I've paid my dues on the travel piece, so I personally, and I mean personally, understand the stress. I remember running through airports with little children, baby seats, strollers, diaper bags, and trying to figure out exactly how much of everything to have in case some eventuality might, and believe me, it always did occur. I remember seeing those couples on that plane for whom everything seemed so organized and, I don't know, what's the word? Neat. Organized and neat, with smiling, well-behaved children. That was never our family. We were always the ones bumping into people as we struggled down the narrow aisle with at least one screaming child and invariably another one who needed a diaper change mid-flight. And let's not even try to discuss nursing on a hot, delayed airplane. Happily, those days are behind us. Now, I am the traveling single parent's best friend. You want me sitting next to you because I'll happily hold your baby and I won't be giving you a dirty look. And usually I have something to entertain your kid in my enormous Mary Poppins pocketbook and enough disinfectant to satisfy the newest parent that it will be clean. It's a win-win situation because I get a baby fix and a parent knows when they've met safety. Plus, it's a plane. It's not like I'm going to take off. Haha, get it, take off, no pun intended, with their kid. And there are others like me. Trust me, I've seen them. On the other hand, I am from New York, and I know how to expletively use it. I understand airports are stressful situations, and as such, people will deploy from their defense mechanism toolbox using whatever works best. I actually support that. What I do not support is abuse of the kindness of strangers. Yes, I realize I sound like Scarlett O'Hara now. I was sitting waiting for my plane, and I saw an individual approaching with his support dog. We can do another program on support animals. I'm 100% in favor of properly trained emotionally support animals for those who qualify. And it's also true. We live in a society with other people. I know many people who travel with their well-trained support animals, and it works well. These two women who were sitting next to me, neither of whom I knew previously, we were waiting for our planes, and they immediately expressed superficial support for the man. "Oh, that poor man," they exclaimed. Meanwhile, I observed the dog sniffing strangers and the man walking erratically. To my trained eye, while he may have been emotionally impaired, at the moment the most pressing issue is that he was clearly intoxicated, and his dog was not appropriately behaved. As he got closer, I could smell alcohol on his breath. We all know and recognize alcohol use disorder is real, needs to be addressed, and we all recognize when someone is taking advantage of the system. One could argue he was drinking because he was nervous about flying, but this looked like a case of chronic untreated alcohol use disorder. I truly don't know. But what's more important, his erratic behavior to me coming onto a flight situation was problematic. What's more, I knew the women weren't thinking that poor man. I said to them, well, he has alcohol on his breath, and an emotional support dog should not be approaching strangers and smelling them. And that's all I said to them. But we professionals know this does a disservice to all people who require emotional support animals and gives credence to those who believe emotional support animals are nonsense. And indeed, there are those who abuse the kindness and privilege of a society that understands this need. Not 5 minutes later, I saw a woman in a wheelchair with a cane. But instead of holding her cane safely across her lap, she was holding it 90 degrees in front of her like a weapon, and it was a hazard to all those around her. Again, we live in a society with other people. As I thought of those individuals, it was very much every person for themselves, and the two women exclaiming that poor man when they knew full well that wasn't the case, they were enabling this situation. We don't want to encourage a society that promotes victimhood as a state, but we do want a society that is compassionate, empathic, and sensitive. That requires us to be honest with dishonesty. We have to call BS when we see it. You don't need an emotional support donkey in a hospital. Yes, I've seen that request, and it may actually have been granted like a miniature horse or something. I mean, ridiculous. But maybe you need an emotional support cat in your lease. And maybe we all need to be a little more honest about calling out the truth when we see it instead of enabling this pathological behavior. I'm Dr. Renee Kohanski for the MD Edge Psychcast.
And that concludes this week's edition of the Psychcast by MD Edge. It's time for this week's credits. The Psychcast is hosted by MD Edge Psychiatry Editor-in-Chief Dr. Lorenzo Norris. Our lecturer this week was Andrew Penn. Show notes are authored by Dr. Jacqueline Posada. The Dr. RK segment is written, recorded, and produced by Dr. Renee Kohanski. Psychcast audio producers are Jeff Bauer and Gina Henderson. MD Edge podcasts are produced by executive editors Denise Fulton and Kathy Skarbeck, multimedia editor Terry Rudd. Our social media is produced by Kyla Clark, and I am your audio engineer, audio editor, and the voice of the Psychcast, Nick Andrews. Thanks for joining us on episode 88 of the Psychcast by MD Edge.